Welcome to Research in Action, brought to you by the Division of Research at Florida Atlantic University. Before we get started, a few logistics. Because of the number of attendees we have today, we cannot accommodate oral questions. So if you have a question, please hover your mouse at the bottom of your screen here. There's a Q&A button that you can push, and please type your question. As soon as our presenter is done with her presentation today, we will go through as many of these questions as we have time for, but not to worry, any question that is being posted there will be answered eventually as we are collecting those and then putting question and answers on our website. Also to let you know, there is a Let's Talk Research website that is to be found on the Florida Atlantic's Division of Research website that shows you all our offerings during this time, during the virtual time. With that, I'm going to introduce our speaker today. COVID-19, we're all mostly sitting at home at these times, very unprecedented times, and also times that bring up very unique questions. You know, who is going to get the next face masks that are available, even toilet paper? Who should get the toilet paper that may become available today and be gone in 5 minutes? You know, if and when there are vaccinations, who should be vaccinated first, and so on. So Dr. Heinze, Katherine Heinze, got her Ph.D. in nursing from the Johns Hopkins University, and then did a postdoc fellowship, which is an additional education at the Berman Institute of Bioethics. So she then joined the faculty here at Florida Atlantic University in the College of Nursing in 2019. And what I just related to you is part of her research studies. So with that, I'm going to turn it over to Dr. Heinze.
Thank you so much, Karen. Let me start my video here. Okay, hello everyone. It's such a pleasure to be here with you today. I wish I could see all of you in person, but I guess this is the next best thing. So I'm just going to share my screen here with you all, and then we can get started. Okay, great. So hopefully you can all see that now. Great, so today I just thought we could start by talking a little bit about bioethics. It might be something that you're familiar with or not familiar with, and so I thought I could just explain a little bit of kind of what goes into the bioethics field. And then I'm just going to share a very few facts about COVID-19, and then talk about some of the ethical considerations in social distancing, in allocating scarce resources, and then considerations for healthcare professionals who, as we all know, are facing huge burdens right now. So to start off, I'm just going to talk about what is bioethics. It's a multidisciplinary field that applies moral theory and ethical principles to issues related to health and healthcare. There are many different types of professionals in the bioethics field. There are clinicians like myself, I'm a nurse. There are nurses, doctors, social workers, genetic counselors, all different types of healthcare professionals work in research in bioethics. And then in addition to the clinical folks, there are also social scientists and philosophers who, of course, are more interested in the more theoretical side of the field. And then there are also clergy involved in ethics, because anytime you're talking about the right or wrong thing to do, there can be a spiritual aspect to that. So common questions that bioethicists ask are, what is the right thing to do? What are our obligations to each other? And how can we maximize benefits while minimizing burdens? My time, when I was getting my postdoctoral fellowship, it was 2 years I spent at the Berman Institute of Bioethics at Johns Hopkins, and it was a really exciting experience just to be in such a multidisciplinary field and to hear all the diversity of opinions and viewpoints. And I'd never experienced that before, of being able to take an ethical issue and think about it, you know, from different theoretical standpoints, but then from also different disciplinary viewpoints as well. So it's a very exciting field to be in. One of the main things that bioethicists consider is called principlism. And the idea behind principlism is that it's an ethical framework for approaching complex medical issues, and it helps to distinguish the most important factors when making decisions and that hopefully lead to a mutually agreeable course. In a pluralistic society such as ours, it can be difficult to come to an agreement on a course of action. Of course, anytime you put more than one person in a room, there's probably going to be some disagreement on what the right thing to do is. But when you live in a pluralistic and diverse society such as ours, where people are coming from very different theoretical viewpoints, spiritual and religious viewpoints, it can be hard to decide on a course of action. And principlism kind of gives everybody something that they can agree on, no matter what theoretical standpoint they come from. So you just focus on specific ethical principles that you feel like apply to the situation at hand. In bioethics, there are 4 main ethical principles that are usually used to address these situations, and then others can be pulled in as well as necessary. But the 4 main ones that we usually talk about are respect for autonomy, or respect for persons, meaning that whenever possible, people should have the right to decide for themselves what course of action they would like to take. Obviously, this isn't always possible, particularly for those who have diminished capacity, whether they may be unconscious or something like that, or also because of age. Children, you know, don't have the capacity often to weigh the pros and cons of a you know, life-changing decision. So part of that principle of respect for autonomy is making sure that protection is in place, both for those who are able to voice their opinions and their values and wishes, and for those who aren't. The next principle is beneficence, which means just to do good. As healthcare professionals and healers, we always have a mandate to do as much good as possible. So that's the second principle we keep in mind. And the third principle is non-maleficence, which is to do no harm, which is a very important principle to consider, particularly in unprecedented times. One of the worst outcomes could be to do harm. And then finally, we think about justice, equality, and fairness, making sure that the benefits and the burdens are equally distributed among the people who are affected. So that's just a crash course in principlism and bioethics, and that's kind of the viewpoint that most bioethicists come from when they are dissecting ethical issues. So just a few facts about COVID-19. I'm sure you guys have probably seen all these before. The last time I looked at the website where they're tracking cases, there were a little over 1.2 million. I'm sure it's even gone up since then. I think I put that number on there yesterday. There were over 71,000 deaths, which is also still climbing daily. And just when we talk about scarce resources in the United States, there are 68,400 ICU hospital beds for adults. So when we talk about, you know, resources that are available to us, we have to think about the number of hospital beds that are available should we need them. And then also on the economic side of things, which is another important ethical consideration in COVID, there have been over 30 million unemployment claims in the past 6 weeks. So there's obviously been a huge impact on that side of things as well. So moving on to talking about ethical considerations in social distancing. We are all probably tired of hearing the word social distancing. There does seem to be good evidence that it does prevent the spread of the disease. And so governments all around the world are obviously very invested in understanding how social distancing can be enacted and how they can use it to protect the health of citizens around the world. Now, anytime that there's a public health initiative like social distancing, excuse me, anytime a public health issue like this is enacted, it's important to remember that not everybody views these public health initiatives in good faith, and for good reason. You know, for over 100 years, public health has been doing wonderful things in the United States, but it hasn't always been the case, and they haven't always acted ethically. And so when we think about the past and past public health initiatives, it's important to consider who our audience is and who may or may not trust the information that's coming. And just as an example of this, just two real brief examples. From 1932 to 1972, so for 40 years, in Alabama, there was a syphilis study where they just followed male participants who were known to have syphilis. And even though in the course of the study in the 1940s, penicillin was invented and was known to be a treatment for syphilis, it was never offered to the participants of the study. So it was a highly unethical study, just designed to see, you know, what happens to people with syphilis. And the men in the study were affected, their intimate partners were affected, their children were affected. So it's things like that that really create mistrust in the community. And then another example of this is the Guatemala STD research that went on from 1946 to 1948. And this was when the US conducted research in Guatemala where Guatemalans were knowingly infected with STDs so that we could study the course of the disease. So once again, just a real failure of ethical principles there. So in thinking about social distancing and how to approach the public, that has to be one of the considerations, is how do we build a partnership with the public so that we can move forward with trust. So when we think about who is at risk in this whole COVID situation, as you all know, there are kind of two sides of the coin. There's the health risk and the folks who are at risk, at a greater risk to get coronavirus and experience a more serious version of it. And then there are the folks who are at economic risk. And sometimes these people are the same, and that is the case with people of color. It's been found that people of color have an increased risk of serious disease due to a higher rate of underlying health conditions like asthma and diabetes. And it's also been found that people of color have had increased challenges accessing healthcare due to a lack of insurance, either having no insurance or being underinsured, just not having that same capability to even access the healthcare system. So we know that people of color are at a health risk from COVID, but then on the flip side of that coin, they're also at an economic risk because they have higher rates of employment in service jobs than whites, and also a more limited ability to absorb income declines. Also thinking about who is at risk, anybody with an underlying health condition, specifically immune compromised, such as folks who are in treatment for cancer or HIV, people with diabetes or asthma, older adults who are over 65, and then those living in group situations or shelters, whether that could be a prison, a homeless shelter, a domestic violence shelter, a college dorm. We know that people living very close together are also at increased risk from coronavirus. So when we think about the ethical considerations in balancing these two things, the health burdens, and we want to maintain life and health, and then we also want to maintain economic opportunity so that people have the ability to live their lives and maintain their health by doing things like eating. So a few things that were reported from the Hastings Center, which is a kind of a bioethical think tank, and they said some of the main ethical considerations should be balancing public health with civil liberties. So like I mentioned earlier, government should be very forthright with information, share it very freely to garner the trust of the population that they're looking to serve. And they should use the least restrictive means possible to protect public health. So, some cities have enacted a quarantine and others have not, but the general ethical principle should be not to do any more, not to make it any more restrictive than you have to. And then protecting the most vulnerable should be one of our main objectives as well. So kind of those people who I mentioned who are at risk will need special consideration for those living specifically in group settings and people who can't change their group setting where they're in. And you'd like to think that most people are rational and that if you share information with them, that they will listen to it. And so self-isolation is preferable to mandated isolation whenever possible. There are times when mandated isolation is absolutely appropriate, particularly for people who have COVID or who have been exposed to it. But for the general public, whenever possible, self-isolation is the preference. And then some other ideas that have been floated to maximize the benefits of social distancing while decreasing the burdens, particularly the economic burdens, the mental health burdens of being shut inside, the physical burden of not being able to exercise like normal, to socialize like normal. A few ideas that have been floated out there would be to try to take more advantage of outdoor activities since the virus doesn't spread as quickly in an open air setting. So you could enact policies that encourage outdoor activities like no contact sports, such as surfing, golf, sports where you're not touching the same ball or running into each other like football or soccer. And then, hikes are, I've seen lots of things online about socially distanced hiking, where, you can go hiking with your own household or maintain a distance from those that you're hiking with. One economic idea that's been floated out there as an ethically permissible idea would be to allow restaurants to open for outdoor dining. So to mitigate the risk of spreading the virus, make sure the patrons are far enough apart from each other, out in the open air to mitigate some risks that way. And another thing, a lot of people have been missing their religious services. And so they said maybe there's a possibility of hosting religious services outside where people can be distanced from each other, but still experiencing a service. And then it's also going to be very important moving forward to make sure that everyone has masks and enough hand sanitizer so that when they do go out, they can mitigate those risks as well. It's probably going to be a very long time before we can get back to the way things were until there's effective treatment and effective vaccine. We're just going to have to really think about ethically how we can help people to have their economic opportunities and to be engaged in activities that are good for their mental and physical health, but then also mitigate the risk of the coronavirus. So when we think about allocating scarce resources, it's very difficult. And like Karen mentioned a few minutes ago, scarce resources can kind of run the gamut. So anything from, there are vaccines in development, thinking about when a vaccine is available, who's going to receive it first and why. There are many medications that are being tested right now for their efficacy in treating coronavirus, but the production of these medications won't be able to be ramped up for a number of months, if not a year. And so thinking about who should receive medication, hospital beds, ventilators, the services of healthcare professionals who are equipped to take care of patients with COVID. There are many, many resources right now that either are already scarce or have the potential to be scarce. And so there are many considerations when thinking about it. And one of the first things is that in the setting of scarce healthcare resources, the focus shifts from individual needs to maximizing benefits from the community. Our whole healthcare system is built on meeting individual needs. making sure that each individual has access to the care that they need, can make the decisions that they want to make for their own health care. But when there are scarce resources, it's just not possible for each individual to direct their own care like it is in the context of abundant resources. And so the shift has to be from thinking about the individual to how do we maximize these resources that we have for the community. And that can be a tough transition to make. Healthcare providers are really trained to consider the needs of the individual. And so it can be an ethical challenge to even make that mind leap. So as far as ethical principles that we might want to consider in a pandemic situation where resources are scarce is first and foremost to maximize the benefits. We want to save as many lives as possible and life years, meaning we want the people who live to have many years of healthy life ahead of them. One thing to consider is that justice piece, or treating people equally. So figuring out methods to ensure that folks are treated equally. And just one example of that would be, for example, random selection for somebody to receive a scarce resource. Like if there were a lottery to get the vaccine, for example, when it's available. Another thing that has been posited as an idea is to promote and reward instrumental value. So to give priority to those who have benefited others in the past or who have the potential to benefit others in the future. And an example of this would be a healthcare worker who has the knowledge and the skills to treat other sick patients may receive priority in scarce resources. And then finally, one other idea that is possible is to give priority to the worst off. Thinking an example of this would be to prioritize the sickest or the youngest. So I have a chart here it's from a article in the New England Journal of Medicine, and it's looking at these ethical values and then how they may be applied to COVID. So when we think about maximizing benefits, we want to save the most lives, and that should really be a very high priority when we analyze this. And then also, like I mentioned, in terms of life years, we want people to enjoy many healthy years after COVID. So that should also be a priority in deciding who receives what resources. As far as treating people equally, one way you could say to do that is first come, first served. But that idea is discouraged because it really is not an equal application of resources. It doesn't rely on any sort of framework or any ethical consideration. It is kind of just whoever got there first. And another reason that this is being discouraged right now is that in theory, people who get sick later on may be the ones who were the most committed to social distancing and following the directions and policies that were set in place by governments to protect folks. And so you wouldn't want to put those people at a disadvantage for following the rules. But another idea for to treat people equally, like I mentioned, is random selection. And that could be a tenable possibility when you have a group of people with similar prognosis. So if you have a pool of people who have a similar prognosis but not enough resources to go around, then that is a case when random selection might work. As far as instrumental value goes, you can think about instrumental value in the past as in somebody who has already contributed to the good of others, it has already benefited others. Or you can think about it prospectively, like who has the potential to benefit others the most. And once again, you would generally use this when other factors are equal. It would not be the main deciding factor, but it could be just another layer to it. And then in the case of giving priority to the worst off, you could use this so long as it aligns with maximizing benefits. You would never want to use the sickest first policy if there wasn't going to be a benefit. So if it's just another consideration when you feel like it aligns with maximizing benefits. And the same with youngest first. Okay. So finally, I wanted to get to ethical considerations for healthcare professionals. I'm sure you've all seen in the news just the effort that our healthcare professionals are going to right now and the burden that we are placing on them every day when they go to work. And it's a difficult burden to bear. So every day, clinicians, when they go to the hospital, must balance competing obligations and commitments. First and foremost to their patients. That's kind of the contract that a clinician has with a patient, is that they're there to be a healer and to help them. But also, clinicians have obligations to their families, which these has been called under concern by a lot of clinicians who are saying they don't have the proper protective equipment to complete their job. So it pulls into tension that duty to be for the fidelity to their patients, and then their duty to protect their families from the coronavirus. They also have obligations to the healthcare institutions they work in. Healthcare institutions are hierarchical structures, and so there are always policies in place that they have a duty to uphold. And then clinicians also have a duty to themselves, to their own integrity, their own sense of right and wrong. And it can be a big challenge to balance all of these things. Just even under regular situations, it's difficult to balance all these things. And now, in light of coronavirus, it's become that much harder. There's a concept called moral distress, and it's a form of moral suffering that many healthcare professionals have said that they experience in the course of their duties. And the idea behind moral distress is when you feel like, as a healthcare professional, you either know the right thing to do and you're constrained from doing it, whether it's that the patient would prefer to go a different direction than you feel is right, or there are institutional policies that prevent you from doing what you feel is right, or other things like that. So you can either feel like you know what the right thing to do is and feel constrained, or you can feel like you're just not even sure what the right thing is. And that might be the case with limited resources. When you're the healthcare provider, you're the one looking in the face of the patient, and that can put you in a really difficult situation where you just wish that you could give everybody what they need and the care they need. And it can create this internal distress that has been called moral distress. And this has been widely studied in the healthcare setting, and many healthcare professionals have reported that it's a burden, and it can lead to burnout and even wanting to leave the profession. So when we think about individual level responses to moral distress, some signs and symptoms of it on an emotional level, might be feeling powerless or feeling overwhelmed, feeling depressed or anxious, over time feeling bitter, cynicism or shock. You can display signs of grief when you're put into these very difficult situations where it feels like there's no way to do the right thing. And then, like I mentioned, it can also lead to burnout. So those are some emotional things. As far as the physical symptoms of moral distress, you can have many signs in your body that this is happening to you, like heart palpitations, GI disturbances, insomnia, fatigue, weight gain or weight loss, or susceptibility to illness. And another part of this can be spiritual distress, including a crisis of faith, feeling like you've lost your self-worth, a disconnection from your community. And then finally, some behavioral responses to moral distress can include impaired thinking, nightmares, lashing out at others. In my research team, where we talk about these things, we always talk about, how sometimes maybe you have a bad day at work and you go home and kick the dog or yell at your kids just from that pent up emotional energy. Or you can just be, generally agitated. So when we think about how we can protect healthcare providers in the context of scarce resources and in the context of COVID, there are 3 specific recommendations that have come out, and this is specifically from our colleagues in Italy, where they have had to face decisions like who is going to get a ventilator and who will not. So what they have recommended is that the clinicians who are providing the bedside care should not be the ones to make the decisions of how the resources are allocated. Because it's just too great a burden to put that on the people who are providing the hands-on care. So they recommend a triage officer, and that there should be kind of consensus over the criteria for who gets what care. When we're balancing these ethical principles of maximizing life and thinking about instrumental value and some of these other ethical principles, these should be set out in a flow diagram basically, and there should be a triage officer who's responsible for deciding, not the healthcare providers at the bedside. And these triage decisions need to be regularly reviewed by a committee, with ethicists, lawyers, clinicians, just to make sure that we're staying on the right track and that we all feel like we're making morally permissible decisions with our scarce resources. And finally, these algorithms that we use to decide who gets which resources need to be updated regularly, because there's new information coming out all the time. Knowledge is evolving very quickly, and so these algorithms will become outdated very quickly as well. So it'll be very important to make sure that they have the most up-to-date information. For example, if it was decided that a patient wouldn't be on a ventilator for more than 2 weeks, if ventilators were scarce, but then, compelling information came out that said, well, a lot of patients kind of turn a corner at the 2.5 or 3 week mark. Well, then that would be an indication that you need to review that policy. And then as far as the healthcare professionals themselves, I'm sure we've all seen in the news that they have been lacking just the basic face masks and things like that they need to perform their duties safely. And so that should be a very big priority, is getting healthcare workers the protective equipment that they need. And that's an example of the instrumental value, where the N95 respirators and other important protective equipment should go preferentially to healthcare workers who are treating patients with COVID. Ensuring that healthcare professionals have access to mental health services will be very important, since they are bearing such a heavy burden right now. Just making sure that they have a safe place to reach out and talk about those things. And then finally, on here, cultivating moral resilience. And moral resilience is one of the areas that I study. And basic idea of it is helping people to have the capacity to face these huge burdens and maintain their integrity or their sense of wholeness. And so helping people to understand the ethical principles behind the decisions that are being made, helping people to feel like they have a voice in their healthcare setting, and then helping people to understand what their own personal moral compass is and how they can hold their own moral values while also upholding the moral values of the patients that they're treating, and also the moral values of the time that we find ourselves in. So in summary, there are ethical principles that can help to guide our actions during this time. It can help us to come together to some consensus and plot a path forward. It's very important to seek solutions that maximize benefits to the most number of people while lowering burdens. And we want to make sure that the people who are bearing the greatest risk in developing medications and vaccines and things like that are also the ones who are receiving those benefits. And, you know, this is an ever evolving process. It's unprecedented in this generation. And so we need to continually evolve with it, and we need to continually be monitoring the choices that we're making and the ethical basis for those decisions so that we can continue to provide the very best care to patients and help the most number of people. So that is my presentation. Thank you all so much for your attention. And I think we're going to have some questions now. So I will stop sharing my screen.
Great, thank you so much, Dr. Heinze. As a reminder, if you'd like to ask a question, on the bottom of your window, there is a button Q&A. Please type your question there, and I will go in order and ask them to Dr. Heinze as they come in. So very interesting topic, of course, you know, with us mostly all sitting at home right now and having to go maybe to a store or something. What I have observed when I go to the store, for example, and there was a lot of discussion recently, most people now wearing face masks, but you do encounter those who don't.
Yeah.
Do you have any recommendations on how to deal with that kind of scenario?
Yeah, you know, it's hard. Like, America is the country of life, liberty, and the pursuit of happiness, and it can feel like life and liberty are in opposition to each other a little bit right now with that. And so I would hope, like I said, like you hope to rely on your neighbors and friends that if they understood what was at risk, that they would wear a face mask. But it feels like the burden of wearing a face mask is pretty low. You know, like somebody might say it's embarrassing or it's uncomfortable, but it seems like the potential payoff is much greater than the potential burden of something like a face mask. So it feels to me like that's an easier one to say, like, everybody should wear a face mask. But I don't know, maybe somebody out there is allergic or has maybe they have anxiety with having their face covered or something like that. So
it's also sometimes I think it's a question of where to get the face mask from, right? And
right.
Have resources that you get the surgical mask, or you can sew yourself one.
Yes.
You know, that's, or you know somebody who can sew it for you. It's not necessarily trivial at the moment to get the protective.
Yeah, that's another really good point. If we're going to mandate that you need to have a face mask if you're you know, in a setting like a grocery store or something like that, then we also have to provide the means for that to happen.
Yeah. Okay, let me start with the questions here. Can you talk about how ethical decisions may differ between regions, countries, and cultures? Or are all ethical decisions equal?
Yeah, no, that's a really good point. There are very different ethical decisions that people come to. Now, in the ethics community, there are kind of large ethical documents that have been published that generally everybody adheres to. So it's not complete moral relativism. And, you know, as I have mentioned in the past, there were huge ethical failures that have happened. Really atrocious things have happened in the name of medical research. And so there have been, you know, documents that have been put together to kind of say, like, you know, baseline ethical principles. For example, you know, respect for persons. You can't perform medical research on a person without their consent or their knowledge. If there's a treatment for something, you have to offer it to them. Like that syphilis study I mentioned, you know, there was a known treatment and it wasn't even offered. And so there are kind of baseline you know, protections in place so that these atrocious things don't happen. But apart from that, there is so much granular detail that does change from region to region, from country to country, culture to culture. There are some cultures that are more community oriented or more collective in their understanding of which moral principles should take precedence. Like, for example, the example that's coming to mind right now in my mind is Saudi Arabia, where they have more of a collective understanding of which moral principles they're going to endorse, or kind of a theoretical perspective that's more endorsed. Whereas when you're in a more pluralistic society like ours, everybody has their own moral theory, basically. And so you have to focus more on the situation at hand and which ethical principles seem the most useful for that situation. And there's usually a bit of compromise involved. A lot of the things that bioethicists deal with are the end of life, for example. When maybe you have a patient and a patient's family and a healthcare team who all have three different opinions about what's happening, what should happen. And so a lot of times, a lot of the work is just trying to gain understanding of other people's viewpoints so that you can find where the overlap is and you can figure out the best way forward.
Very complex problem.
Yeah.
The next question is, what resources are healthcare providers using to access the latest scientific information that might impact the way they provide care?
That's a really good question. I know that there are many professional organizations and hospitals and universities that are trying to get the latest information out as quickly as possible. But I also know that some of this has been hampered by the economic side of the coronavirus, because we know that elective surgeries are being canceled, and patients are avoiding hospitals at all costs right now unless they really have to go. And so hospitals themselves have taken a big economic hit. And I know that, for example, one local hospital system furloughed all of their nurse educators. And I was kind of panicked a little bit about that, because I thought, isn't this the time when we need nurse educators more than ever? But it's always that balance of, the ideal and then what is. So I think that right now we really are relying heavily on like webinars, on journals, on professional organizations to push all that information out as much as possible. Because it's life and death knowing this information.
It's tricky, of course. All the information that's being circulated is somewhat different from different sources, and it's up to the user, so to speak, the provider, healthcare provider, to actually seek it out. Let me get to the next question here. Can you offer some tips to build or strengthen our own moral resilience?
Oh, yes, absolutely. So I think first and foremost, when you think about moral resilience, you have to have a good sense of who you are, because the idea of moral resilience is that you can face these very challenging times and maintain your integrity or feeling your wholeness as a person. A lot of people say when they go through a really tough time that, you feel kind of bruised and battered, and part of you is missing in a way. And so part of moral resilience is really building that internal fiber and knowing who you are, knowing what's important to you, and knowing that if you're in a situation where you have to set your own morals aside in order for the greater good, for example, a nurse working in a hospital might disagree with a policy decision or how resources are being allocated, but being able to understand maybe that wasn't her choice or her preference or what she would have decided, but she can still be there and she can still take the best possible care of those patients, and understand that she's part of a bigger system. And so not letting those decisions kind of batter you up on the inside. And interestingly enough, there's been some research that shows that clergy have particularly high moral resilience. And we don't really know why yet. We're in the middle of doing research studies to try to figure these things out. But one theory that's been posited is that clergy are really encouraged to have a strong internal life, kind of an internal dialogue with themselves, and and maybe that is part of what helps them, move on with these things.
Great, thank you. The next question actually gets us a little bit away from the ethics in the medical sector, which the attendee is commenting on that and complimenting me on that. That was an excellent summary on the medical sector, but he's wondering whether how to apply ethics in the political sector.
Political. Well, thankfully, I'm not a political scientist because, wow, I mean, it does seem to be a very challenging time politically. Honestly, I come from a scientific perspective in the scientific community, and so I put a lot of stock in that knowledge and information, and it's been shocking to me to see that others don't hold that same perspective. And so I think it's very easy to feel distressed about what's happening politically. It's very easy to feel, like people who disagree with you are the others. And I think one of the best things that we can do from an ethics perspective is to seek to really understand others' points of view right now and understand how, like, their ethical basis for thinking the way that they do. And those are conversations that hopefully are happening on a larger scale on our TVs, but also on a smaller scale in our own communities. I know in my own family, we have a lot of disagreements about politics. And so just trying to be as understanding as possible. And then kind of that same concept of looking for the overlap where we can build bridges together. Because if there ever was a time where we need to try to work together, I think this is it.
Yeah, I would agree with that. Can you elaborate more on instrumental value? It seems deciding who has instrumental value may pose an ethical dilemma as well.
Yeah, that's definitely true. I mean, it's kind of dicey trying to assign value, like somebody's value to society. So that's why that instrumental value would never be the primary consideration, because you're right that somebody is making a subjective assessment. But especially when it comes to healthcare providers, you have to think that in order to get through this pandemic, we need the expertise of healthcare providers. And so especially when thinking about the protective equipment, whether somebody gets an N95 respirator to go to the grocery store versus the doctor who's in the emergency room, you have to consider that we owe our healthcare providers their protective equipment. And so you're right that there really is, there's a strain there, and hopefully it won't ever get to the point where we have to get really granular with that. But I think it does have to be a consideration of who, even, our leaders in our community, like who's kind of holding things together right now, and who do we really need in order to move forward.
Thank you. The next question is related to the category of healthcare professionals. And you would like to know if you're including custodial staff in that category in the hospital, custodial staff in the hospitals, and should they be included in that category?
Yeah, I think they should. I was thinking about that actually when I was making my presentation, when I chose to phrase it as healthcare professionals. But there's actually, a broad spectrum of individuals who are needed to run a hospital. And you couldn't run a hospital without the nutrition workers who cook the food and deliver it to the patients. And like you said, the custodial workers who are cleaning. I mean, what a valuable service that is right now. So I absolutely do consider the entire healthcare team. But I think the slight difference is maybe that while there is a certain expertise that you need for somebody like a member of custodial staff, I'm sure it's way more complicated than I even know it is, as far as, which cleaner to use for what and how often and when and how to use them safely. So there's certainly a knowledge basis to that that's very important. But when you think about, it takes 11 years on average to become a physician. It takes 3 or 4 years to become a nurse. So I think that everybody on the team is very, very valuable, but it's easier to train, for some of these other positions, for some positions than others.
Great, thank you. Coming back to the decision making, so when a hospital has to prioritize patients, as you mentioned earlier, ICU beds are a limited commodity. Are those decisions made individually by the hospitals, or for example, the governors involved, and is the decision making a little bit more uniform across the heart and hip areas?
Ideally, it should be more uniform. I think that there would be small differences from, institution to institution, but ideally it should be, like I mentioned, like the triage officer for the hospital, for example, should be in communication with other triage officers, and nobody should be an island in this process. If it gets down to it and like we don't have enough medication, and we're making choices as to who gets the medication, it really shouldn't be this hospital does it this way and that hospital does it that way. And I don't think it should necessarily either be the government, whatever that means, saying it has to be this way. I think that we all need to come together as a community of ethicists, scientists, community members, families. There need to be all of these perspectives are important and need to be voiced. And like I mentioned, particularly the perspectives that usually aren't voiced are also very important. Whenever you do a research project, you have to run it through an institutional review board who reviews the ethical aspects of your research and approves or disapproves it. And on these review boards, it's there are ethicists, there are clinicians, there are community representatives, there are lawyers and leaders, and I would imagine the process would be kind of similar to that, where you want a diversity of voices.
Mm-hmm. Good point. We're almost out of time. I'm going to finish with one last question, but before I ask that, just a reminder, we will collect all of the questions and have question and answers on our website within a couple of days, as well as the recording of this presentation. Next week, Thursday, again at 1 p.m., we will have another Research in Action series, that time a completely different topic on sea level rise. So I hope you can join us then. And Dr. Heinze, the last question is, what do you envision as some of the biggest changes in healthcare that will emerge from the COVID-19 pandemic?
Wow, it feels early on, so it's hard to say what some of the long-term things will be. I really sincerely hope that we're never in a situation again of healthcare providers not having the protective equipment that they need. I hope that that's one of the biggest changes that comes out of this. I think that it will be interesting to see if, now there's so much telemedicine happening, and I wonder the extent to which that will really take root now that we've kind of proven out what can be done from a distance and what can't be done from a distance. I think that going forward, we may see a lot more of that.
I had to use it recently and I really liked it. I got to tell you, I didn't have to go anywhere. All right, with that, thank you very much, Dr. Heinze.
Thank you all so much.
We will post the recording and the remaining question and answers on our website. Thanks again.
Sounds good. Thank you.
Bye.
Bye.